Hey there, I'm Dr. Barbara Woods, and welcome back to the Intergenerational Trauma Therapist Show, where today we're going to talk about using assessment to tailor treatment plans for specialized intergenerational trauma therapy. So, this is a huge area. It is just as complex as some of the families that we work with. So, this will be an overview, and in my course, I go a lot deeper into assessment and tailoring treatment plans. So basically, today we'll talk about relational neuroscience as the foundation of assessment and treatment planning. So we want to know about autonomic regulation and co-regulation. We want to look at attachment, child development, and family resilience. We'll also talk about milestones or markers of progress in the overall intergenerational trauma therapy, and of course, cultural inclusivity, because that's a really important part of designing treatment plans that fit for specific clients. So first, we're going to look at how we tailor those individual and family therapy plans for intergenerational trauma and the specific needs that complex families have in this situation. So there's four primary areas of assessment that we want to look at, and those are autonomic dysregulation, attachment strategies, child development, and family resilience. So, with autonomic dysregulation, what we want to look at is the impact of this dysregulation on individual well being and also the relationships within the family, because we look at autonomic regulation and the ability to co-regulate as really a foundation for attachment. So that's how it has such a significant impact on attachment and why we need to really include that in our assessments and our treatment plans. And increasing autonomic regulation is one of the primary pillars of the intergenerational resilience model. So it's just a foundational concept and really needs to be integrated into treatment plans. The next area that we want to assess are attachment strategies. So we want to look at both the parent and the child or teen's basic attachment strategies. And there's different ways to look at attachment strategies. I look at them as they're fluid and flexible, because you can have you can have a secure attachment with one person and have kind of an anxious avoidant attachment with another person. And we really want to look for that disorganized attachment because it's a hallmark of intergenerational trauma. But we want to look at them in both the parent and the child or teen, because those are going to impact each other. And this is the exact spot where intergenerational trauma is transmitted between generations. It's in the relationship between parent and child. So there's those four primary attachment strategies or clusters. There's different ways of looking at this, where some have divided them into 16 strategies. I use the basic ones that are in interpersonal neurobiology, and those are secure, avoidant, anxious, and disorganized. So secure is a child or a parent that can experience separation and feel a little bit distressed possibly, but be able to come back and not have anxiety, not have an emotional reaction, and not withdraw. So it may raise the autonomic dysregulation a little bit, but it doesn't trigger a whole cascade of significant dysregulation. Avoidant is where the child or the parent is kind of aloof. They're not engaging very much. They're kind of defended, or they're just disengaged. So they're not really developing that relationship. And basically, even if we have avoidant attachment strategies, our nervous systems are still looking for connection and co-regulation. So even if somebody has an avoidant attachment, those strategies that they use, they're still looking for and needing attachment and relationship. Anxious is more where people who use these strategies become highly anxious when there's separation. So they pursue a lot, they want to know where you're at, they're texting all the time, or they have to know exactly what's happening, and they have a lot of anxiety about their relationship. And disorganized, it's the title disorganized is really kind of a misnomer because they're actually organized except for one subset. Because they're managing people who have a disorganized attachment strategy framework, they're really managing a fight and flight response and kind of shutdown. So you'll see more dissociation with disorganized attachment strategies, and you'll also see kind of this come here, go away kind of approach where they'll pursue and pursue. And then the minute somebody turns around and kind of offers relationship, they can get highly triggered and kind of pull back or even become aggressive. So, under that disorganized umbrella, there's three important subcategories or sub strategies that are important to look at. And that is punitive and controlling. So, that's a child who makes demands of the parents. I want it now. No, you won't. And they're just very punitive, and they control the parent because their anxiety and their attachment is so fragile that they're in constant pursuit. And to lower that level of anxiety, they have to feel like they can control their caregiver. So the other one sometimes doesn't look like it's disorganized because it doesn't look disorganized until you take the strategy away. And that is a parentified or caregiving controlling presentation where a young person in the family steps up and manages everything. They become responsible for siblings, for the parent, for everybody's well being. And that strategy helps them regulate and manage, but it's not healthy, but it helps them get through those situations. And it is organized. The problem is when there's a boundary put in, or when they can no longer do that caregiving controlling, if they're removed from the parent, if they're separated from siblings, if an adult steps in and says, that's not your job, that's my job, you need to just be a kid, that's when you'll see that kind of back and forth, I hate you, don't leave me kind of thing, because it's triggered. They're regulating and managing their dysregulation by focusing in caregiving and kind of controlling the situation. The last one is it's a disorganized, and this one is truly disorganized, but it is called that because it's very unpredictable. So there's no pattern or organization to the behavior. It really becomes just very unpredictable to recognize what the triggers are or predict what may happen and try to use some strategies to prevent that. So that one is really more difficult. It's more rare. It's also linked to higher dissociation. So it's really important to keep those things in the back of your mind when you're treatment planning. So you can use either formal assessments or informal assessments. I have trained in Theraplay, and I've used the MIM or the Marshak interaction method, where you set up tasks for the parent and child to do together, and you're really looking at how they work together in four different categories of parent-child relationship that you want to see. You can also do this fairly informal and do it by interview and get information from the parents, or if there's a social worker involved. The most important thing to identify is how disengaged or how reactive the relationship is, because that's going to help you determine kind of what way are you going to go with therapy first. So, what we need to do, if you have a highly reactive family, we have to take the heat out of the family system. If they're highly disengaged, we need to kind of warm it up and take the cold out of the family system. And we do this by addressing that autonomic dysregulation and building more effective connections through co-regulation and some attachment strategies. So the thing to really look for when you're looking to treatment plan for families is if the parent's trauma is overwhelming and significantly impacting and may be a primary cause of attachment difficulties, we may need to treat the parent's trauma first before we try to do the more of the parent coaching or try to build that attachment, because that trauma can throw the whole treatment plan off if we don't address it, because that's probably your primary thing. Now, you'll see this when you've had a more recent trauma or the trauma is very active and very unresolved in the caregiver. So in your assessments, if you find out that there's a recent trauma, say there's a traumatic death or a weather event, or children were apprehended and taken out of the family system, those are things that may need to be treated first so that the parent has the capacity and can do the regulation and the co-regulation. So now we're going to look at child development, and what we're really looking for is the developmental impacts on the young people in the family. And so this follows, I believe it's a framework through developmental trauma with Bessel van der Kolk. But the article that I got this information from was by Cook and several other authors. If you want that information, just let me know and I can get that for you. So there's several domains that we need to look at in child development to determine what kind of impacts there have been of the developmental trauma. And the reason we want to look at these is they can cause difficulties in meeting treatment goals if they're not addressed, particularly if they're an additional difficulty that requires a referral to another practitioner like an OT, a speech language, or a psychologist to have a cognitive assessment done. So those areas are, of course, attachment. We've already talked about that. So we want to look at how attachment has been impacted based on the developmental trauma. We also want to look at the biological impacts, which include sensory difficulties and medical difficulties. So the sensory difficulties can really be kind of what we would call a red herring, or a piece of kind of misinformation that we may put in there in our treatment plans, but it's really not something that we need to or we can address in the therapy that we're doing. So that's where it can look like ADHD, or it can look like trauma, but it may be sensory processing that they get overwhelmed and can't process sensory information, and it causes dysregulation. That's totally different than dysregulation caused by trauma reminders or an attachment relationship. So we really, if you have a child or a teen that's seems to have some sensory difficulties, and that you may want to refer them for an OT evaluation and to get those strategies so that it supports the rest of therapy. The medical difficulties, there's like loss of muscle tone, there's autoimmune difficulties. So you'll see a lot of colds and those kinds of things. So you just want to make sure if there's anything you're seeing that looks like it may be the developmental impacts on biological development, that there's a medical provider that's kind of in the system and supporting the family as well. So next we look at affect regulation. How do they process emotions? How do they identify emotions? So if they have difficulties with affect regulation, they'll have difficulties with self-regulation. So we want to look at kind of in a finer framework, how do they manage emotions and how is this impacting themselves, their relationship with the parent and the family overall? Some kids who are impacted by developmental trauma, they can't identify emotions, and they can't label them, so they don't really know how they're feeling. So you may ask them, "Oh, that must have been really hard for you," and they'll, "I don't know. I don't know." And they won't be able to label it or connect it. So then they can't use that as good information to use coping strategies for, or to feel joy, or to sense danger. So that's a really important thing, is to check how much Can the children or the teen identify and label emotions? You want to look at that probably in the parent as well. These developmental impacts, you can also see them in the parent. So if you're kind of looking at the overall family, that's actually a really good thing as well. So with affect regulation, they may not have interoception or awareness of their own internal states. So they won't recognize that they feel the pit of their stomach if they're kind of anxious, and then they don't sense, their neuroception doesn't detect danger because they're just kind of dampened down, and they don't have those internal sensations that kind of cue or trigger us that there's something happening inside of us, in our environment, or in our relationships. And if they can't identify emotions, or they can't regulate emotions, they usually can't identify what their needs are. So they won't ask for things that they need, or they won't know that they need this type of support and help rather than this type of support and help, because this whole area is kind of a gray area for them. So determining how well versed they are with affect regulation is really important as you're going through the therapy process and treatment planning. Dissociation is also very important to assess, both in the parent and also in the child. So you want to look at kind of the intensity, the degree of dissociation, and the frequency of how often dissociative episodes are occurring. I look at it through a structural dissociation lens, where there's parts of awareness with either or awareness or lack of awareness. So they'll have a structural dissociation looks at kind of your animal defenses of fight, flight, freeze, attach, and it depends on how much the person is aware of all those states. And sometimes they will be fully embodied in a fight response, and there's all these other parts of themselves are not online. And as structural dissociation continues, those experiences can get kind of walled off, where there's amnesia for that fight or flight part. And it's really important to know how far this has gone, because that's really going to become a primary part of therapy when you're working with both the children and the parent. And this is especially important to know if you have a child that has disorganized attachment, or even a parent with disorganized attachment, because dissociation is a hallmark of disorganized attachment strategies. So it's really important to get information on dissociation and then to work that into your treatment plan. We also want to look at how much behavioral control, or kind of self-regulation of behavior, does a child or teen have. Might want to look at the parent too. So impulsivity, if they're impulsive, it might be kind of fight or flight, or they may have an additional difficulty. So it's important to have kind of a differential diagnosis of, are there other things occurring, like ADHD, that could significantly impact the effectiveness of treatment if it's not addressed before you start therapy or in the process. Also want to look at aggression towards other people, self-destruction. Are they self-harming? Do they bang their head? Do they cut? All of those kinds of self-destructive behaviors. We want to look at unhealthy coping strategies for teens and parents. It might be substance use, could be relationships. So we want to look at what kind of coping strategies are they using to regulate themselves, but they're actually probably causing other problems. We also want to look at kind of a continuum of oppositional to over-compliance, because these can be trauma responses. Oppositional behavior can be digging in your heels because people aren't safe and you're going to keep them away from you. Over-compliance may be what some people are calling fawning, or it might be please and appease, where they give up their own needs in order to kind of regulate all the people around them. So these are all really important aspects. May need to have some collaborative work with the schools if you have a child or a teen with a lot of behavioral difficulties, just so that there's consistency across environments of what's expected and how to intervene with those. The next area to look at is or domain of impact would be cognition. So we want to look at attention and executive functioning. And this is because when a child is experiencing developmental trauma, the higher cortex or thinking brain goes offline because the brain is hijacked. So those executive functions aren't going to be developed, and the child or the teen may have some executive dysfunction. Those strategies are very different than trauma treatment, but they can go hand in hand with it. So it's important to know, do those need to be added into a treatment plan at some point in the therapy process? You also want to know, do they have difficulties with perceiving responsibility? Like, do they take responsibility for everything and they're such a bad child that the whole world is wrong because they're the bad child? Or are they not able to take responsibility and get quite defensive because that's kind of a strategy that they've had to use or they've experienced that many times? So you want to know how much responsibility, or how, if they take too much, or can't get the concept of responsibility. Want to look at learning difficulties. A lot of kids have difficulties with learning math and language because of that hijacking of the brain. And we also want to, of course, look at language development. I've worked with some kids that have been in neglect situations and probably the agency didn't have enough to apprehend during that time, and they weren't exposed to a lot of language, and their language development is significantly impacted. So then you're going to want to know that also for how you do therapy. So you may have to do more sensory or hands-on work rather than incorporating books or strategies like that. The last area we want to look at and assess is self-concept. So we want to see, do they have a consistent self-perception of themselves that has some flexibility, but it's consistent? Or do they tend to shift their self-perception based on who they're around? So if somebody comes around that likes sports, then all of a sudden, oh yeah, I love sports too, and I'm going to be a great athlete, but they've never played sports. That's that sense of identity or self-perception that has some difficulties because of the impact of developmental trauma. Also want to look at how enmeshed are they in other relationships? Do they really have a high need to be in relationship with other people to feel safe? Or do they not want to be in relationship at all? Do they kind of avoid relationships and avoid connection, or are they highly dependent on it? Another area is their body image. Like, how do they see themselves? This is where we can get into eating disorders and a lot of self-loathing because their body image and the amount of shame they may have. And that's the last area we want to look at under self-concept, is if they have excessive shame and guilt. And a little reminder is, between the ages of 5 to 7, that's a state where the brain waves are in a certain pattern that they're related to kind of a hypnosis state. So they're very susceptible to messages. Their brain can figure out patterns, but it can't fact check. So a lot of shame and guilt can be kind of almost installed when they're between 5 and 7. Because of the experiences that they have, and they interpret it that I've caused this, or I'm a bad kid because this happened. So it's really important to get a handle on how much shame and guilt is there for a child and a parent. So then we move on to the last area under that relational neuroscience that we want to look at, and that's family resilience. And so the family resilience map, this is an intervention that I teach. We look at rigidity, like how rigid and it has to be this way, to how chaotic and everything's kind of all over the place and there's no stability. and then that resilience of kind of the window of tolerance. And that's from Dan Siegel's work with interpersonal neurobiology, to look at these concepts in that framework of rigidity, chaos, and resilience. And the areas that we're going to look for is finding meaning. Like, how do they create meaning? Is it very rigid that everything is interpreted that the world is against us and everybody outside of our family is unsafe? Or is it kind of a evolving narrative of it's just kind of chaotic and it may not make sense, or it may get really intense one way and then it shifts and it gets intense another? Or are they able to find meaning in the midst of difficulties or more difficult situations? So finding meaning and realistic optimism, which is the next area we look at, we have to be really careful of these, because if somebody's just experienced a recent trauma, has had years and years of complex trauma and developmental trauma, these concepts can be pretty difficult. So we don't want to have rose-colored glasses and everything will be okay. So we want to find meaning that helps integrate the experience. And we also want to have realistic optimism, where it might be little pockets of things that can give them hope. That's also why we want to get in there and take the heat out of the family nervous system or warm it up, because that will give them a sense of hope that they can change what's happening in their family and healing is possible. So we have finding meaning, realistic optimism. Next one is flexibility. How flexible is the family in dealing with difficulties and dealing with each other and dealing with agencies or schools or things that are outside the family as well? How connected are they to themselves, their self-awareness? How connected are they with within their family, their extended family, and with community and community agencies? What kind of social resources do they have? Do they have parents that can help watch the kids if something happens and the parent can't be there? Do they have friends in the area? Do they have supports that they can go to if they need some help? Is there clear communication? Are they siloed and don't talk, but everybody feels really upset and angry? Or is there's some clear communication between family members? Emotional expression, that this ties back to the impact on emotion recognition and regulation. So how much emotional expression is in the family? Are they really kind of hot and very expressive, possibly angry all the time, or big explosions? Or is it very quiet and cold and you can't even figure out what people are feeling because it's so kind of under the surface and not expressed? And if emotions are expressed, are they validated? Or are they, I'll give you something better to cry about, or you haven't had it as hard as I have. Those things can be very difficult if with emotional expression, if it's not validated. The next area is, how do they problem solve? If they approach a problem as a family, how do they get through that in a way that helps support their growth and development in the relationships in their family? We want to look at their cultural connections. How much can they integrate their history, their cultural practices to have that sense of belonging and identity? And also spirituality. Don't have to be in an organized religion, but how do they understand and interpret kind of the meaning of larger things that happen, to understand kind of their experience in the world? So in some families, you may look at this much later than in the beginning of therapy, because you may have to address that autonomic regulation and attachment first and get that kind of stabilized, and then you can pull in these. So this might be kind of a second or third phase of developing a treatment plan to include these things in there. If they already have them as strengths, I would definitely include it to maintain that or to continue to hone that, because that's a positive that they're bringing in and it's a sign of resilience. So we have to have, because these families are complex, because there's so many impacts on different members of the family, from the grandparents, parents, children, we have to have structure when we're working with these families, but we also have to have flexibility in how we do that treatment planning. So there may be flexibility that we need with treatment goals, because they come in layers of impacts, that these impacts become more obvious the longer you are working with somebody. And as you work through the phases of therapy, you'll see layers kind of getting peeled away, that you have to kind of keep an eye on that and have the structure, but also the flexibility. If something is coming up and it's directly related to meeting treatment goals, that may need to be incorporated into a treatment plan. At the same time, you don't want to be chasing everything everywhere and changing the treatment plan all the time, because then there's no structure to it. So it's a very delicate balance of how to balance the need for structure and a framework with the need for addressing more immediate needs or layers that kind of emerge through therapy. We also have to remember, with these families, a lot of times they continually experience traumas. So sometimes they live in neighborhoods where there's a lot of crime, and somebody may try to break in their house, or there might be a shooting. So we have to kind of watch and monitor for real-time traumas that could significantly impact therapy. So other things that may happen is that they may have a report to a child welfare or child and family services, where now there's kind of that level of trauma. They're very anxious about it. It directly impacts the family. So we want to watch for that as well, because those newer additional traumas or more acute things can totally throw off the stabilization, and then no amount of skills is going to help them unless you help get in and stabilize for that particular experience. You may use some of the same interventions, but you have to kind of address that and help them work through it to a point that they can go back to the work that you're intending on. So now we're going to look at the milestones and markers for progress. Like, what do you look for? And it's really hard to come up with exact things because families are so different. So we want to set realistic and meaningful milestones when we're working with intergenerational trauma. And the milestones may be directly related to the impacts and the degree of impacts. So if you have, like, family one has extreme impacts, the family's very chaotic or highly shut down, there's not a lot of communication, there's a lot of reactivity, or a lot of shutdown, and there's the attachment is really struggling. If you teach a parent about autonomic regulation or trauma informed understanding of behavior, and that their child may be having a fight or flight response rather than just being defiant or doing it on purpose, that for some families is a monumental task. And the parents, I've seen parents that are like, "Oh my gosh, I can't believe that's how I saw that. It's so different than what they usually interpret behavior or their degree of reactivity." So sometimes these things that look so little, they can be monumental for these families, because they may have never experienced co-regulation. They may have never experienced healthy, secure relationships, where that is a huge, huge impact for them. So we have to look for even the small little things. Another family may autonomic regulation might be quicker to accomplish because they've maybe done their own treatment and therapy, but attachment may be difficult. So parents, this is a really important thing to watch for. Parents who've done individual trauma work, and maybe before they had kids or as the kids were younger, if they've done individual trauma work, it doesn't necessarily translate to their attachments. And that, even though they may feel like that trauma is resolved, and it can be resolved in their own reactivity, their own experience, where they no longer have the symptoms of PTSD, it may still have impacts on their attachment. So you have to watch for that really closely, because they will come in with almost like a sense of, I'm healthy, I should do this. It's the child's behavior that's the problem, but it's really in the attachment and the relationships between. So we don't want to tell them that your therapy didn't work, or because it did work, it helped them regulate. They're leading a pretty good life, but they're having difficulties in the relationship with their children. So with the intergenerational trauma program, phase one is aimed at decreasing parent-child reactivity, or increasing engagement if there's a lot of shutdown in the family. Also increasing earned secure behavior, but the parent can still be impacted by their own unresolved trauma. So we're inching towards autonomic regulation and increased earned secure attachment. So the goal of phase one is really to take the heat or the cold out of the family system, but they may still have difficulties because it's just a foundational level and it's just a start. So they may have less conflict and decreased dysregulation. They may understand behavior better. They'll have improved co-regulation, but there's still unresolved trauma in both the parent and the child. So phase two is specifically for the caregiver to resolve and integrate their unresolved trauma. So it directly works on the parent's trauma and reduces the impact on the parent-child relationship. So they have a greater capacity to cope with stressors. They don't get overwhelmed and shut down, and they don't get highly reactive. They have a lot more self-regulation. So they have that reduced autonomic reactivity, more self-regulation, and they have fewer trauma symptoms that impact their life and their relationships. So phase three, the treatment goals, this is where we address the child and teens trauma and build connection in that family resilience. So we're going back and kind of really creating a solid foundation of connection and attachment. So you'll see reduced trauma-related behaviors in the child or teen. They'll have less periods of dysregulation, maybe less aggression, more self-regulation, more ability to co-regulate. You'll see that the parent-child relationship becomes much more based on co-regulation rather than co-dysregulation or triggering each other. You'll see better self-regulation. If there's improved co-regulation with the parent, you'll get better self-regulation in other environments and in the parent-child relationship. You'll see in between family members, you'll see more flexibility and understanding and compassion, and you'll see more connection and a more heartfelt connection, because all of that reactivity or shutdown has been kind of addressed so that they can form those relationships. And there's awareness and integration of the previous generation's resilience. We can't forget that, because that's what's carried through those generations to help the survival of the current generation. So if you have more developmental impacts, like in sensory learning, behavioral, these may create extra barriers that require more support and intervention. Some of them you're going to have to refer out. If you are trained in supporting sensory needs, then you incorporate that in your own treatment plan. And the milestones are and markers of progress they're going to be different in every family, and they need to be realistic. So one of the main goals is to build and maintain hope that healing is possible and life can be different. So now we're going to look at cultural inclusivity and making sure that's in your treatment plans and why that's so important. So it's important because some cultures have had collective experiences that are traumatic in nature. It's not because of their culture or what their cultural practices or beliefs are. It's because they belong to that culture and it happened to that group of people. So many of our clients have experienced a lot of racism and bias. So this is an important distinction for them to separate that it's not the cultural practices or the culture itself. It's the things that have impacted or those collective experiences of a cultural group. So the ways that we as therapists need to kind of keep this in our own treatment plan or self-development plan is we really need to do a lot of continuing education and learning related to culture. So that's really important. It becomes more and more important as you work with more diverse clients, or if you're working with a specific group of clients that come from a different cultural background. So we want to do a lot of self-reflection. We want to know our own biases. There's a really good book that is a 30-day, it was a 30-day Instagram challenge, and she turned it into a book and a journal. It's called Me and White Supremacy. It's by Layla Sayad. I don't know the last name, but you can find it in any kind of bookstore. And it's a really good look at all these different areas that if you're not from a cultural group, you may have no awareness that you have some of these beliefs that are your clients will feel them and they need to be addressed, and you need to do a lot of self-reflection on that. Getting consultation related to culture to be able to support your understanding of the culture and how it may be impacting a certain family is really important. May need to do cultural adaptations to therapy interventions. You don't want to do this in a way where you're teaching the client their own culture. You want to do it with some guidance and with a lot of humility. And you also want to have a mechanism to have feedback from clients. Like, how do clients experience your services as a member of a cultural group, that there may be some differences? Do they feel heard and understood? Do they feel like you have understanding? Or do they feel like you're helpful, but you don't get that piece? Or do they feel like you're not helpful because you have some biases that they can pick up on? So that's really important for us to work with. When we're working with intergenerational trauma, because certain cultural groups have experienced huge traumas as a collective, and we want to be able to effectively work with them. And they're so different between groups. Like, I have therapists that are in Afghanistan, and therapists that are working with indigenous people, and therapists in India, that all of those are very different, and we can't learn every culture and how to incorporate that, but we can sure adapt our models with help and support from some experts or consultants in those cultural areas. So when we adjust for cultural sensitivity, a couple of the things that I've done is I do some genograms, and sometimes I do timelines. Where a genogram, if you don't know, is a structured representation of generations in the family. It's very linear. The oldest generation is at the top, and it works down to the current generation. That linear approach for indigenous peoples, sometimes it's not within their cultural perspective. So I have taken that and done it in a medicine wheel instead, if their band or their cultural beliefs incorporate the medicine wheel, which it's a circle with 4 quadrants, and it's divided into baby, youth, adult, and elder. So doing a genogram, we would put members of the family at this point in time, who are the 0 to 12, who's 12 to 21, 21 to 55, and 55 on for baby, youth, adult, and elder. And then we kind of map out different things like substance abuse, residential school attendance, and we look at all of those things, including the resilience factors, so we can see it kind of clearly on in that medicine wheel. And the timeline you can do for the individual person, like from 0 to 12 in that baby phase, that's the ages that they consider the baby phase. What was happening in your life? What kind of experiences have you had that are impacting you today? Then moving into youth, adult, and then if they're not an elder, if they're not 55 or over, or if they're a teenager and they don't have adult or elder, sometimes I ask them to uh, identify what they would like it to be like and what they envision their future to be. So those are two just very simple cultural adaptations that if you're working with Indigenous people who also incorporate the medicine wheel, it helps just communicate within their cultural framework, just being very careful not to try to teach them what a medicine wheel is and what it's about in their culture, because that can be very offensive for them. um, so learning things like that you can incorporate into your treatment plans and your interventions is also, it's just really, really helpful to signal to clients of diverse backgrounds that we are working toward and emphasizing reconciliation and respect for their culture. So, the key takeaways from this episode are that relational neuroscience is really the key foundation in assessment and treatment planning. We want to look for that autonomic regulation, attachment, child development impacts, and family resilience factors. We need to know those milestones or markers of therapy progress and when to kind of shift and be flexible and when to stay more structured. And we also want to do a lot of cultural inclusivity if we're working with people from different cultural groups. So next time, we're going to look at difficult case presentations. So this is a really important one because the more impacts that you have from intergenerational trauma, the more difficult behaviors and case presentations or complexities of family systems you'll find in the therapy room. So I hope you have a beautiful day, and I will see you in the next episode.